for that, and we don't take it for granted. Almighty God, as we do start our programs this morning, we thank you for the guests that have come to share with us. We thank you for the CECs that had the grace of you to be nominated or appointed to serve in our county governments, and particularly to serve in the health space. God, as we start our program for the morning, give us the knowledge and insight that it may impact us so positively to the extent that when we go back, we will have the best interest of our citizens in our counties. I pray and trust in Jesus' name. Amen.
Thank you so much, Claire. So we will quickly do a round of introduction. The secretariats kindly let us have mic roaming in. I will start from my left. Kindly just say your name and the county you are coming from. Your Excellency, we have 47 county government, the new CCs. Today is their induction. I was actually saying today is their wedding. This is the first time now we are meeting. So it's very, very important for us also as secretariats to be able to know who they are. We also have former CECs, though we have some few who bounced back, who are also with us in this house. So we felt it's very important for them also to come and share their experiences with the new CECs. So we'll just do a quick round of introduction. We are starting from my right. Kindly just say your names and then your county or the partner. If you are a partner, just say your partner. And then if you are from ministry, then just say you are from the ministry, kindly. So just 1 minute of introduction.
Thank you. My name is Sitiene from the Ministry of Health. I also thought you'll ask me about my marital status.
Good morning. My name is Michael Kibiwot from Elgeyo Marakwet County.
Good morning. My name is Kotut Sam from Uasin Gishu County.
Good morning. My name is Professor Richard Muga from Homa Bay County. Thank you.
Good morning. My name is Professor Mwanje from Vihiga.
Good morning. My name is Dr. Mutaha Kangu. I come from Kakamega County. I live in Nakuru County. I work in Nairobi County. I work with the Council of Governors. Thank you.
Good morning. My name is Dr. Emmanuel Wamalwa. I work with the Council of Governors. Thank you.
Good morning. My name is Joshua Motisia from the National Council for Persons with Disabilities.
Good morning. My name is Bakari Mohamed Barua, National Council for Persons with Disability, Nairobi.
Good morning. My name is Fatima Ravad. I am with U.S. Centers for Disease Control and Prevention in Kenya.
Morning, everybody. My name is Lilian Mutea with USAID Kenya and East Africa.
Good morning, everyone. John Owoth with DOD.
Good morning. I'm Dr. Maswai Jonah from PEFA DOD.
Good morning, everyone. Good morning. My name is Regina Ombam. I work with the East Africa community.
Good morning. My name is Joseph Mutueleli and I work for Jacaranda Health.
Good morning, everyone. My name is Zoya Munguti, working with the USAID, Kenya and East Africa. Thank you.
Good morning, everyone. My name is Harun Hassan, Executive Director, National Council for Persons with Disabilities.
Morning, everyone. My name is Cynthia Kahumbura, and I'm the Country Director at Jacaranda Health.
Yes, good morning. My name is Dr. Dirango Anjuki Meshak, Country Director at AMREF. Thank you.
Good morning. I'm James Lowasa, Deputy Governor Isiolo, also the CEC Health.
Morning. My name is Claire Parclair from West Pokot County.
Morning, ladies and gentlemen. My name is Albert Taiti from Laikipia County.
Good morning. My name is Peter Mwarogo, Kilifi County.
Good morning. My name is Beatrice Naholi from Busia County.
Good morning. My name is Ruth Koech from Nandi County.
Good morning. My name is Franz Driga from Embu County.
Good morning. My name is Gifton Mukaya from Taita Taveta County.
Good morning. I'm Edna Tanui, Kericho County.
Good morning, Dr. Nasir Lekudere, Samburu County.
Mjamboni, jina langu Kibor Keitany kutoka Wizara la Afya.
Good morning, I'm Wanjala Pepela from Trans Nzoia County.
Good morning, I'm Peter Waithaka from USAID, Kenya and East Africa.
Good morning, my name is Gecho Yandura Kumutoriara, Tharaka Nithi County.
And I am Dunstan Achwaka from USAID, Kenya and East Africa. Thank you.
Good mornings. My name is Robert Dhuomwangi, Nyeri County.
Lucy Nganga, CDC Kenya.
Good morning, Masinjeru, US CDC Kenya office.
Good morning. I'm Emmanuel Okumo with the U.S. Centers for Disease Control and Prevention, Kenya.
Good morning, everyone. My name is Habiba Ali from Wajir County.
Good morning. My name is Dr. Catherine from AMREF.
Good morning. My name is Boniface Mbuthia. I work for ThinkWell. We support national and county governments on healthcare financing.
Good morning. My name is Dr. Amalwa Andrew from Bungoma.
Good morning. My name is Cyril Wayongo, the County Attorney, Bungoma.
Good morning. Dr. Daniel Yumbia, Machakos County.
Dr. Joseph Murega, Kiabu County.
Good morning. My name is Dr. Mahmoud Eda, County Executive for Health Services Mandera, formerly the Vice Chair of the Health Caucus, and currently the Acting Chair of Health Caucus, CECMs.
Good morning. My name is Dr. Nicholas Mwandi, Viga County.
Good morning. My name is Leo Gega, Kisii County.
Good morning, everyone. I'm Julius Nyerere Awor, Migori County.
Good morning. My name is Dr. Mbogua, Murang'a County.
Good morning. My name is David Nibaya, Tharaka Nithi County, County Attorney.
Good morning. I'm Anthony Namunkuk, CC Health, Narok County.
Good morning. Francis Gwama, CC Health, Kwale.
Good morning. I'm Professor Gilbert Kokwaro from Strathmore University.
Good morning. Dr. Joseph Sitonik from Bomet County.
Gideon Thronira, Health Chairman's Office.
Good morning, everyone. Maxwell Marks with the Perfect Coordination Office.
Good morning. My names are Gilbert Mogambi Osoro from the National Health Insurance Fund, and welcome.
Good morning, everyone. My name is Goreti Apondi. I'm a communications consultant and now supporting the Council of Governors. Thank you.
Good morning. I'm Stephen Osingo, formerly manager Marifa Center Council of Governors. Today I'm a rapporteur for the induction. Thank you.
Good morning, all of you. My names are Dr. Bernard Wesonga, Kakamega County.
Good morning, everyone. My name is Melissa Wanda. I work with PATH Kenya.
Good morning. My name is Titus Monenen Tomaeti from Mission for Essential Drugs and Supplies, USAID Supply Chain Strengthening Project.
Good morning. My name is Ayuni Sambio from MEDS on the USAID Supply Chain Strengthening Project.
Good morning, everyone. I'm Dr. Solomon Sirma, CC Baringo County.
Good morning. I'm Claire Wanyama. I'm the former CEC member for Health, Trans Nzoia County, and also former Secretary General of the CEC caucus. Thank you.
Good morning. My name is Mebo Abor, Council of Governors.
Good morning, everyone. My name is Sarah Omache. I'm the former CCM Health Services, Kisii County. Thank you.
Good morning, everyone. My name is Esther Somoire, former CEC Health Kajiado, former Treasurer, CEC Caucus, and now working with KEMSA. Thank you.
My name is Dr. Paul Musila, CEC from Makueni County.
Good morning, everyone. My name is Wairi Mugakuo from USAID.
Thank you. Good morning. My name is Dr. Ombati Timothy Mokua, CCM Health Nyamira.
Morning. Ahmed Omar, CECM Health Garissa.
Good morning. My name is Alex Leshinka Kilowa from Kajiado County.
Good morning. My name is Dr. Zakayo Kariuki Gishuki, immediate former CECM Health Nakuru County, now CECM Health Nyandarua County.
Good morning. My name is Vincent Iboro from Development Partners in Health Coordination.
Good morning. My name is Roslyn Omolo, CC for Health, Homa Bay County.
Thank you very much. Secretariats, kindly introduce yourself behind.
Good morning. My name is Robert Rapando, COG Health Directorate.
Good morning, everyone. My name is George Capio, COG Maarifa Center.
Good morning. My name is Rose Chebet, COG Secretariat.
Good morning. Jemima Kuta. I work at the Health Directorate at the COG. Good morning. My name is Gerald Muka, Communication Officer at the Council of Governors, supporting the Health Committee.
Thank you very much, everyone, for the quick round of introduction. I think you've all heard that we also have former CECs, former caucus leadership in this. CECs who have actually moved from one county to the other. So you have good stories around. For the new CECs, you have good stories to hear from these outgoing CECs. So kindly allow me to read remarks on behalf of the CEO, who really loved to be with us. She was here yesterday. She wanted to participate the 3 days with us, but unfortunately she was called for an urgent matter in Nairobi. But she has given us her blessings to continue. At any one point, she may join us virtually. So kindly allow me to quickly go through her remarks. Health Committee Chair, Council of Governors, His Excellency Mudhomi Njoki. We are also expecting Honorable Justice Jacqueline Mogeni, who was our former CEO, Council of Governors, County Executive Members of Health present, CEO representative from NHIF, representative from KEMSA, Waziri Esther Samoire, former. We also have Kenya Law Reform Commission represented here. The CEO, National Council of People with Disability, Mr. Harun Hassan, who is seated here in front. You will be able to engage with him. Professor Gilbert Kukwaro from Strathmore University, Karibu Sana. County and national government present here. You've also had representation from the Ministry of Health. Distinguished guests, ladies and gentlemen, good morning once again. Good morning. Hamjambo. Nataka tuchangamke, tumeanza tu saa hii ni mapema. So it gives me pleasure to welcome you all to the induction meeting and to congratulate you all for your appointment on behalf of the Council of Governors. The main objective of this induction is to adequately prepare the county health leaders to effectively manage all the devolved health functions and ensure delivery of quality health care services across all the 47 counties. As part of the third generation of county government, we have the advantage of experiencing and lessons learned from the past 10 years of devolution, which when harnessed will translate into improved healthcare service delivery at the county level. In the last decades, Kenya health system has undergone significant changes, and you can basically witness that as it aligned to the Constitution of Kenya 2010, that devolve health services and strengthen right-based approaches to health through providing that every Kenyan citizen has a right to highest attainable health care in this country. The fourth schedule of the Constitution of Kenya 2010 vests the principal role of service delivery to the county governments, while the national government is vested with development of national health policies, standard setting, technical support for capacity needs, and national referral facilities. Further, it's important to note that although health sector functions are assigned to both levels of government, there is profound achievements in collaboration. Counties, in collaboration with development partners and the national government, have made gradual and significant investment in the health sector across health building blocks. The impact of this investment include, but not limited to, improvement of health infrastructure across the counties, which has brought healthcare services closer to the people. The health facilities in the country have increased by 6%, from 13,190 in 2021 to 13,772. On the other hand, with support from the national government, 14 regional cancer centers were established across counties. 2 of these centers are comprehensive cancer centers and therefore have increased screening, chemotherapy, surgery, and recently radiotherapy services for the people. Increased number of human resource for health. I can just quickly give an example. Before devolution, for example, in Mandera County, you had only 1 MO. That was before devolution. And as we speak, we have 64 MOs of specialized cadres. You don't need to travel all the way from Mandera, which is 800 plus kilometers to Nairobi, to seek even services. For example, like renal services, dialysis, ICU, and the rest. So there have been a lot of recruitment at the county level, and I know county have actually given a priority to ensure that there is quality standards in terms of service delivery. Establishing a robust health product and technology system, like for the blood and blood products. I know we are also working closely with the Ministry of Health. We have 12 blood transfusion satellite centers across 12 counties. The establishment of this center will increase collection of blood at a tune of 67,056 pints of blood. Initially, Your Excellency, when you want blood, for example, you are in Garissa and you really need blood to save a life, probably you may wait longer because it has to come from Nairobi and it is transported by bus. Remember, you cannot transfer 1 pint of blood from Nairobi by air. Because of cost effectiveness, you have to actually save that mother, but then you have to wait longer to save that mother, or you need to refer that particular patient. Improvement in disease prevention and health promotion through investing in the establishment of community health units. There have been 8,847 community health units across the country. And I know because of prevention and UHC, counties have actually given priority in terms of, establishing and strengthening community health units at the county level and increasing recruitment in terms of CHV and capacity building them. Because basically we are saying we've been focusing so much on curative, but we just now want to focus on preventive health care. And for us to focus on preventive health care, we need to actually strengthen our primary health care levels. That is level 2 and level 3, and even at the community level. Achievement of remarkable improvement in health indicators. Maternal and child health indicators improved. The proportion of skilled deliveries increased gradually from 2014 to 2015 from 53% to now 78%. So as much as we have the national figures of maternal death, at facility level you can also be able to gauge yourself as a county. What is my rate? Because you need to just look at the skilled deliveries and the number of maternal deaths you had at the facility level. But in the KDHIS, that is actually an improved indicator. The fourth antenatal care attendance has also increased from 46% to 51%. Always when we talk about antenatal care, you hear like mothers come and seek first antenatal care, second antenatal care, but when you reach the fourth antenatal care, the mothers actually disappear. So that is why like now we really need to empower also the community health volunteers to actually track for us these mothers so that they complete the fourth antenatal care. Ladies and gentlemen, despite this achievement, we all have great tasks ahead of us to sustain the gains that have been made by the sector, by our predecessors, and leverage on these successes to achieve even more. Allow me to point out some challenges that counties encounter in relation to the health service delivery. There is minimal funding to counties by Exchequer, and most counties are struggling with adequately funding their health functions, given the limited fiscal space. I know Our Excellency will really talk about this. If you have delay in disbursement of funds, as county, you have to move on. You have to provide service. You don't need to interrupt that. So, but then what do we need to do as mitigating measures? We really need to ring-fence our health funds so that as much as we wait for the delayed disbursement of funds, service delivery is not interrupted. But we are going to have deep dive of that discussion even within the next 3 days on how we can be able to improve on that. MOH continue to propose some policies, regulation, laws, and policies that reverse the gain of devolution. The Public Health Institute, for example, that has been established some few days to election, and authorities among others. We are also going to discuss this. Like now we have authorities like NAC, we have authorities like Kenya Tissue and Transplant. Some of these authorities actually claw back devolution, and Schedule 4 is very clear on what is the role of the county government and what is the role or the function of the national government. So that is a discussion that is also ongoing. I know it is going to be addressed at a certain level. There is need to accelerate the review, costing, and further unbundling of remaining health functions. The policies we are currently using, like we have a task force that are currently working on some of these policies that have been developed before devolution, but now we are in devolution. What do we need to do better? Because we keep on developing. For us, as secretariats and COG, we are very alert, because anything that claw back devolution, we have to be alert and actually fight for devolution. So those are things that we actually are reviewing. I know Dr. Mutaha is here with the Ministry of Health and the Intergovernmental Relation. Task force will actually review all the policies and see what they need to unbundle and what needs to be transferred. There has been delay in activation in some health coordination and partnership spaces. I know our partners seated here, the chair of Development Partners of Health, Kunle, will actually say something about this, like interagency coordinating committees, thus resulting missed opportunity to optimize both state and non-state resources. Finally, I take this opportunity to convey the assurance of Council of Governors' commitment to maintaining the momentum and focus on the attainment of UHC in the country. We will work in collaboration, cooperation, and consultation with all stakeholders for the delivery of quality, affordable, and accessible healthcare to Kenyan citizens. I wish each one of us a success execution of mandate of the Office of the County Executive Committee members of Health seated here. Thank you very much, and God bless you. So as we do this, kindly note that you have a bag. That bag is full of materials, full of information. You have reference manual, and you also have a abridged version of a manual in your bags. We also have all policies that have been reviewed by the Secretariat and through with our chair. And so if you really want to refer, you can quickly refer to those manuals, as we also have this progress of induction. So kindly allow me now to go to this next session of this. I want to invite our panelists, our partners, to quickly give remarks. Because of time, we may limit, but everybody who is in the program will be able to speak. So allow me to invite Dr. Meshak Indirangu, Country Director of AMREF, to come and say a word. Tumpigie makofi.
Thank you very much, Katra, for those huge achievements you have spoken about. We commend the COG for the overall leadership that you're giving in that space. Good morning. Allow me, my name is Dirango from AMREF, Country Director. I'm very honored to be here on behalf of our organization, AMREF Youth Africa, and just to recognize the leadership that is represented here, Katra on behalf of COG, Dr. Kahubura on behalf of Jakarta Health, Harun with the National Council of People Living with Disabilities, Brian Redman, PEPFAR, John Kwene, DPHK, and His Excellency Mudomi Joke, the chair of the COG Health Committee. Good morning once again. From AMREF, we first of all would like to start by congratulating each one of you, all the CECs, that we do know that it was a process of nomination, and thereafter you have to be vetted, and you came out successful. So congratulations for that achievement, each one of you. Having said that, just to highlight that what is on you now, each one of you, is a huge responsibility. We know that when the governors who have appointed you were doing their campaigns, health had the greatest weight, even if it was not the greatest volume, but it had the greatest weight. The promises around health carried maybe more than half of the weight. But the good thing is that you are experts. That's why you have been nominated. Congratulations to the one who has gone to a new county, serving in 2 counties. And what we would like to do as AMREF is just to share 3 ideas that we think may be of value as you embark on this journey. The first one, and you can always remember these 3 ideas using the 3 Ps that we would like to share with you. The very first one is the role of partnership and multi-sectoral collaboration. You are coming into the health sector where you have been there, but you're starting this journey within the context of limited resources. PEPFAR will tell you that what the organization used to give to Kenya several years ago, more than $500 million, probably has fallen to between $200 and $300 million or something like that. And every development agency will tell you that. And we are also coming from a COVID-19 pandemic that has really affected our economy. So you're working within very resource-constrained settings. So with that, how do you as a county health executive work to mobilize blended financing for services and also for innovations? And what we'd like to encourage us across all the counties is to really look into developing partnership frameworks very early on in the work that you're doing, ensuring that FBOs, CBOs, NGOs, private sector, public-private partnerships, including clinics and pharmacies. For example, they find a lot of missing cases of TB across the country, are part of the health sector strategies that we are forming across the counties. And also recognizing that it's not just partnerships within the health sector, but multi-sectoral collaboration. Remember, primary health care, multi-sectoral collaboration is one of the pillars of primary health care. Recognizing that sometimes, and many times, it's by working with sectors outside health that you get the biggest impact. For example, the financial institutions and the ability to mobilize financing for sanitation, like we have seen in Busia, more than 1.5 billion shillings mobilized for sanitation through working with microfinance institutions. Or if we go to Turkana, where we have seen the County Department of Health working with the Animal Health Department and other departments to have integrated mobile outreaches that have all these sectors working together. And finally, the whole issue of also seeing partnership between counties at national level. How do we foster that conducive working relationship with the national government, actively participate in the health sector intergovernmental consultative forum to address key priority health sector issues of concern between the 2 levels of government. And very soon, I understand by the end of today or tomorrow, you'll have a new chair of the CC caucus. How the chair of the CC caucus will work with the CS Health, the Director of Medical Services at the national level to make sure that those 2 levels are working in harmony. So the first P is really partnership and really thinking about sectoral collaboration and how the partners in this room and your leadership, your governor, can support that partnership framework. The second P is primary health care. We know that 40 years ago, or rather more than 40 years ago, in 1978, 45 years ago, the whole idea of primary health care was born. couple of years ago, 4 or so, in Astana, we revisited the whole idea of primary health care. And would like to still stay with that primary health care is the engine for delivering universal health coverage. Universal health coverage is a dream, it's an aspiration. But the engine, the vehicle for that, for getting to that, is making primary health care work. But how do we make that one work? Here is the thing. When you think about primary health care, think about systems for primary health care. And then think about each of the 6 building blocks of the health system. Financing, human resources for health, service delivery. And ask yourself, for each of them, what are the biggest opportunities or barriers that exist between people, the people who elected you, were elected, the government has given you a job. What are the biggest barriers in that block between the people and getting service delivery? A few examples. If, for example, you think about financing, a number of counties have identified that they need to ensure that primary health care financing is working, that each of the counties has suitable legislation, the laws, to make sure that money flows, is ring-fenced, and goes to the primary health care units, level 2 and level 3. And so they are developing legislations for that. And I know a number of organizations like CAMREF and others, we are supporting counties to develop those legislation to ring-fence public, primary health care financing. Another example is in your county, what proportion of residents, I'll call them voters, and their families are enrolled on a National Health Insurance Fund. And we can see NHIF is here. Is it 30%, 40%, 50%? Remember, you are very privileged. Yourself here, you have health insurance. Your family, you have health insurance. What can we do so that all the residents in your county, working with the community health workers and others, have health insurance? So those are illustrative examples. If we go through each of the building blocks, what are the 2 or so things that we can do that have the biggest impact? Because within limited resources, we can't do everything. So you can go through HRH, and I encourage us to start with HRH. How do we ensure that we have harmonious industrial relations? Service delivery, how do we ensure that community health services are working for prevention, early diagnosis, and all that? For example, you know that in Western Kenya, the last couple of years, 800 women and children have gotten diagnosis in their homes because community health workers went and did a malaria test and prescribed treatment for non-complicated malaria. Those are lives saved. Very cost-effective, very low cost per capita, and also releases the health system to deal with more serious issues like delivery, which cannot happen at the community level. So keep asking, what can we do at the community? Community diagnosis and treatment, community screening of non-communicable diseases, and all that. And as we do that, please don't leave the people behind. How do you make sure that you're working with the people? Not only public participation is key in all that we do, but also, and I learned this from one of the counties we had a chat with, I think Busia, I think Beatrice is here, the Waziri from Busia, is the whole idea of having a feedback mechanism. What are the feedback mechanisms that exist between the county government and people in terms of health? When something is broken in the health facility, what mechanisms are there for you to know, for the governor to know that things are not working in this facility and be able to remedy things quickly? So those feedback mechanisms for engaging people are core. And the final P that I would like to talk about is scale. I know as a country we have done so much. The development partners who are here have supported a lot of, they are called pilots. And I know we call it pyrotitis or something like that, always testing things and all that. So the question is, in the county where you are working, how do we begin picking what is working and finding pathways to scale? And pathways to scale are about learning the principles. I was with Rosary Nomoro, the Waziri from Homa Bay, and she was telling this morning at the airport, she was telling it's about principles. If something has worked in this county, what are the principles? What are the critical success factors that have made it work in that context? And how can we use that to scale it to other counties. And I really want to commend the Council of Governors because the Marifa Center is really made for that, to pick those lessons from one county and take them and bring them to the service and provide a platform for others to learn. So let us think about pathways to scale, and learning is a way to do that. And always focus on the principles, critical success factors, and remember, as adults, we learn through experience. We don't learn in a class, we always learn through experience. So as I head Katra, allow me to use this opportunity to also highlight that as AMREF, we are available as always. We are your reliable partner as you embark on this journey, and all our institutes as an organization. Whether you think of the AMREF University, thanks Kajiado because you're already sponsoring a number of your people to go and study at our university. Whether it's the Institute of Capacity Development, various trainings on governance, even emotional intelligence for health workers and all that, just know that we are at hand, including the AMREF Flying Doctors. We are at your service. Just talk to any one of us and we'll be able to connect with you on that. Allow me finally to ask AMREF staff who are here to start, just so that you see them. In case you need to talk to AMREF, talk to any one of them. Please stand up. Just stand up and wave. We have Catherine there. You can talk to her. Then we have Rapado at the back. You can talk to him. Who else? And then we have George at the very back. You can talk to him. Feel free to talk to any one of us, and we'll be able to connect on any of these issues. Once again, our very best wishes, and really looking forward. Thank you.
Thank you very much, Meshach. Another round of applause. So allow me now to invite, as per the program, you see Mr. Gerald Masharia, who is the president of Clinton Health, but unfortunately he's not here, but he has sent the deputy country representative, Rosemary Kihoto. Tumkaribishe. Karibu sana. Clinton Health have really been supporting us, and I know in this induction they also gave us 100% support. So karibu sana, Rosemary.
Good morning, all. My name is Rosemary Kihoto. I'm here on behalf of my country director and the vice president for East and Southern Africa, Gerald Masharia. He was unable to join us today. He's away in Kigali for the African CDC event, but he sends his warm regards and his best wishes. The chair of the Health Committee at the Council of Governors, Governor Muthomi Njuki, Director of Health, Katra at the COG, all development partners present and stakeholders, Dr. Harun from the Council of persons with disabilities, and all the CECs from various counties, all our 47 counties, all protocols observed. I wish to share the remarks of my country director and would like to also share about our experiences and maybe also some insights that we have gained from the various opportunities we've had to work in the counties, and also talk about the opportunities that exist for us to partner going forward. So in the 10 years of a devolved health system, I think as a country, what we have seen is that we know what to do. We know where the gaps are. And as CHAI, we have been a great supporter of the devolved health system from back in 2013 across many areas of your responsibility. There is no area where we have not touched, from immunization to child health to sexual reproductive health to HIV, cancer, TB, COVID, building systems, especially around oxygen. And we have worked with your predecessors and some of you in those spaces. We have seen the good, the bad, and the ugly during this time. And at times we have seen children die because things were not well put together. And we have seen others get well because of your team's hard work, diligence, and dedication. We have classic examples of huge improvements in the health indicators in a number of counties where we are seeing more women being screened early for cervical cancer
and managed appropriately, preventing unnecessary deaths, where more Kenyans living with HIV are receiving better health care and better drugs. And where, we have more exemplars, especially around oxygen and coming out of a pandemic. Counties like Kiambu, Kajiado, I think Madam Somoire is here, Dr. Murega, Professor Muga from Homa Bay, where they quickly went in and built in systems that really supported the response to the COVID-19 pandemic, and many other exemplars we have from the sector. These are areas that CHAI will continue working with you on. We'll continue to support you to ensure that children have a chance at survival by targeting the lead killers of children, such as birth asphyxia, pneumonia, and promoting early and correct diagnosis as well as appropriate treatment. We'll continue supporting the various counties that we're supporting to screen early for cervical cancer and prevent the progression of HPV to cancer using the thermoablation and LEAP technologies. We'll continue pursuing optimal treatments in HIV, making sure that our people have access to better drugs, and of course tackling emerging challenges in this space, such as the advanced HIV disease. NCDs today contribute to 39% of the annual deaths in Kenya. We're losing so many people to conditions that can be easily prevented and treated, especially diabetes and hypertension, and we know if we address them early, we would prevent these deaths. Something has to be done. We need to reorganize our current approach to these chronic illnesses and manage them as such. We need to diagnose our people early. We need to provide them with optimal treatments, which we know are taken for life and are costly in the private sector. And we need to support our patients, especially those with type 1 diabetes, to survive, because I think there's data out there that suggests most of our patients with type 1 disease do not survive into adulthood because we don't provide the best care. So we have to think about how we can build systems that would support our children, our young ones, our mothers, and our adult populations to live and be productive. About 2 weeks ago, the Missing Billion report was launched globally. Many of us may not be aware of this, but there is 1 billion people in this world who are forgotten in our service delivery across health, across education, across social protection. I'm talking about the persons who are living with disabilities. So increasing access to assistive technologies for persons living with disabilities, and especially children who are denied the opportunity to get an education and thrive, will continue being our priority. We have worked on the policy and strategic frameworks, and now we need to reach those in need with the assistive technologies, and I'm happy to see the council represented here. There's a lot of work ahead for us, and we will come down to the counties to build these services because they are almost non-existent. And as you can tell, and I'm sure as you have observed already in the few days you have been in office, the needs in the health sector are huge and many, yet not enough resource. Hakuna pesa, I think that's what we keep hearing. The priorities are already defined by what is killing most of our people. But we need to know what is killing most of our people across our geographies, across our counties. And then, of course, identifying what is broken. How come we're not saving the lives of the people who come into the services that we have built or into our facilities? We also need to leverage the financing opportunities that have remained untapped. And I think what we need from you is a major policy decision, FIF and ring fencing of health resources, and ensuring that these actually go back to the facilities. We will be there to help you improve on your NHIF and Linda Mama claims. These have largely been underutilized. And of course, that to ensure that these monies go back to the facilities that are offering quality services, and that these monies go back to the right things and to build onto those services. We also need you at your level to keep looking at your data and what it is telling you about the disease patterns, about your service delivery, and the coverage you're reaching with the services. I know some of you have reached out to us for support on GIS mapping, and we are here to support all the counties where the need is. to put in place some maps to track key metrics in your geographies and according to your priorities. And now I take this opportunity again, once again, to congratulate all the new members, but to also thank the old members in the House who are here to help us with this process for your service. We wish you all the best, and we want to assure you that our support is available, and you can call on us to support you in some of these areas that I've listed out, and many more that we're working in. We have teams that are working already in all the 47 counties, and we'll be reaching out to you as the new leadership, and we look forward to working together. Thank you.
Thank you very much, Rosemary. Another round of applause. Hello, hello. Another round of applause. Thank you very much. The CEC, the new CECs who are seated here, so you can hear. You have full house of partners. So see, this is an opportunity for you now to start, tapping on that resource, engage them. Please, you can be able to meet them even after break. Try to exchange cards. This is an opportunity for you. So make sure you utilize this opportunity. What is it that they are doing in your counties, and which area do you want them to support you? So you have house again full of partners. Tap on it. So allow me now to invite Cynthia Kwambura, Country Director of Jacaranda Health. She was here yesterday actually meeting the 21 counties they are working in. And this is actually great. I said actually it is networking. It's important for the partners also working within the counties to see and sit with these counties that they are working in, and actually, tell them what is it that they need to do differently on how they can be able to strengthen the working relationship. You have leadership, new leadership in the counties. So karibu sana, tumpigie makofi tena. So we'll be having series of young ladies coming here as country directors. Probably maybe in 2027, you will find a woman president in this country. Tupigieni makofi.
Thank you, Katra. Thank you, Katra. Morning, everyone. As Katra mentioned, I'm Cynthia Kaumbura, Country Director at Jacaranda Health. I'd like to thank the COG for having this session. They had previous sessions as well with CEC's Health. And I want to really commend the COG for all the work that they're doing around induction and the transition for the new government. So really well done. I'd like to recognize the chair, the governor, the Council of Governors and their team, the implementing partners, as well as the old and new CECs, all protocols observed. I won't belabor what my other two colleagues have mentioned. But I will share with you 3 stories from our experiences and what we've seen in counties, and how we can work together and how we can really focus on interventions that are actually driving outcomes. As Jacaranda, we focused on maternal and newborn child health care. So I'll share with you a story of Veronica, and this is an actual woman in one of the counties we're in. Veronica had had 2 miscarriages and didn't know why they had happened, and really had nowhere to turn. As she visited the facility for her ANC appointment, she was told about our SMS program, Prompts. This program focuses on providing information to moms based on their gestation period, and also up to 1 year of the child's age. It's not just about providing critical information, but it's about reminders for appointments. The mom is able to ask questions, and it also empowers the mom with knowledge. So what happened with Veronica? Veronica was actually informed about how to identify danger signs. And as she was asking about question, I'm bleeding too much, what's happening? We actually told her, go to the hospital. This is a critical time, because we knew her. She was also close to her EDD, her due date. She actually kept messaging us as she headed to the hospital, and thank God she actually managed to deliver. She has a 3-year-old son now, and it was a success. But she was able to seek care at the right time and the right place. Delays in mom seeking care is actually contributes to 33% of preventable deaths, maternal and neonatal deaths. So this is critical. And why am I sharing this with you? We also have to keep in mind the journey of our customers, not just moms and babies, but our customers. They come first. We tend to look very much at the system and how the system is existing and working without putting the client, our moms and babies first. So let's put them first. Let us hear their voices. I think one of my colleagues mentioned how are we collecting feedback, giving our moms a voice so that they actually have somewhere to say, this is how my quality of service, the quality of service I received at the facilities. On our platform, we actually collect feedback from moms, and we've seen changes in certain counties. I'll share another positive story. A mom complained that she was not feeling private when she was in the ward. And when the facility in charge received this message, she just put curtains around. And that small gesture actually started making the moms feel like they have respect, they have dignity when they're receiving these services. So how are we listening to our moms, and how are we incorporating that into the systems? Sometimes it's big changes and also small changes, but we have to start listening to the voices of our people. And the second one is really looking at the systems. The other day I was in a county. We went to visit a facility, and a mom said, I came in, I was ready to deliver, but I was not admitted because I was given a list of items I need to go buy, worth 1,500 bob. And on that list, she was being told to buy oxytocin. This was at 2 a.m. She has no clue where to get this. She didn't come prepared with the funds because she thought she would be covered. And imagine you're about to deliver. Your family is the one they're now rushing to find these before you're even allowed to be admitted in the facility. So this is now where we look at the system, and as my colleagues also mentioned, what is the ecosystem around it? Because it's one thing, so the mom has arrived to the facility. What happens there? And we're looking at commodities. We don't deal in commodities, but we have partners who are dealing in commodities, who are dealing in supply chain. So I ask you as the CECs, how can you link us with other partners who are in supply chain so that we actually have an ecosystem? We cannot come as a partner as Jacaranda Health and solve all the problems, but we can work with the other partners who are there to really build the system and the networks that are around and strengthen them so that we are not working in silos. And even as my other colleagues mentioned, financing. Financing and ring fencing is critical. So how do you bring us as partners with you to the same page and to the same table? And just from that, let's look at sustainability. When we look at sustainability, and again, my colleagues mentioned, funds are running out. So how are we going to make sure that these interventions that actually impact outcomes are continued throughout? And I think this is where your task and taking on from your predecessor, for those who were there before, and continuing their good work. How is it that we make this sustainable? How is it that we invest back and make sure that even as as implementing partners exit or their resources are reduced, that you are still investing and making sure that you own these programs and these interventions that are actually driving impact? Another county we are working in, we focus a lot on level 4 and level 5 facilities. What they have done is they've actually taken our mentorship program, they have invested in their sub-county RHCs, and they have invested in trainings for their level 3 and level 2 midwives and nurses themselves as we provide the back end, so that they know that from level 2s and 3s, those nurses and midwives are well equipped to identify emergency areas and can refer as quickly as possible, cutting down the time that it takes a mom to be referred. But we are working together. So they take part of the investment and they're building capacity of their own teams. So that's really how we're looking at sustainability and seeing how can we cost share. So just with those three stories and actually real examples of what we've seen on ground, I'm really looking forward to working with the new CCs that are in the existing counties we're in. And we are looking to expand into new countries and to actually go national. And as we do that, we're asking you to please let us know who we can also partner with so that we don't have to come and reinvent the wheel. We can come and leverage on the partnerships that are already existing and really build in making sure that we're meeting the outcomes and working together. Thank you very much, and congratulations on your appointments.
Thank you very much, Cynthia. Allow me now to invite Ms. Caroline Njuguna, Country Director of PATH. This beautiful conference you have sat in is courtesy of PATH. We really appreciate your support. So, karibu sana, and maybe just give us your remarks.
Thank you, Katra, and I must say the work that you're doing is quite commendable. We do appreciate your leadership and vision with regards to advancing health services. As you've heard, I'm Caroline Njuguna. I'm the Country Director for PATH Kenya, and really pleased to be here. Allow me to acknowledge the Chair COG Health Committee, His Excellency Honorable Muthomi Njuki. Allow me also to acknowledge our development partners. We have Brian Petman, PEPFAR Country Director. We also have John Kinley from DPHK. Allow me also to acknowledge the presence of Ministry of Health leadership, county executive committees, members of health, development partners present here, all protocols observed. Good morning. As PATH Kenya, I must say that we are truly delighted and extremely honored to be part of this important exercise to connect, reconnect, as well as network with our CECs for health, with our MOH colleagues, as well as other partners present. Allow me also, in addition to my colleagues who've been here, to congratulate the CECs for health who recently went through a very rigorous vetting process, and we do look forward to working with you. But also thank the outgoing CECs who are present here for your partnership and your collaboration, which is very critical as the new leadership comes to speed. This meeting, which serves to get the sector started off on the right foot, will no doubt seek also to highlight the gains that we have seen in the health sector since devolution, but also optimize on opportunities to deliver affordable, acceptable, quality, and people-centered care. As PATH, we are delighted to be part of this, and it's very exciting to see the wide range of representation from partners. I think from the speakers before, we've heard that health is very multi-sectorial, and hence the need for all of us to be in the room today. For those of you who may be unfamiliar with PATH and our mandate, we are a team of innovators working to eliminate inequities so that people, communities, and economies can thrive. At our core, we believe that better health moves humanity forward, so we bring a wide range of expertise to find new tools and approaches to the most pressing health challenges. For us, we take a multidisciplinary approach to our work so that we can tackle problems from all angles. Our work in Kenya is clustered across 5 platforms. Just to name them, we work in the vaccine space, drugs, diagnostics, devices, as well as service and system innovation. Here in Kenya, over the last 30 years, we have implemented sustainable health solutions that truly align with the country needs, but also the needs of the priorities. We've partnered and supported the national and county government across a wide range of health domains, naming, just to name a few, from HIV care and treatment, COVID-19 response, primary health care, early childhood development, and many others. And I really look forward to continue that partnership with the counties. Coming back to devolution. Devolution of health system in Kenya has created opportunities for counties to focus on local health challenges, but also explore customized approaches with partners and support health system change, as well as develop systems and capacities in the counties. It also helps with effectively integrating civil society as well as citizens in the decision-making process. Further, it has not only illuminated the health challenges at the sector level and at the counties, but also, you'll agree with me, it has added new challenges to the health sector. As an institution, we see the Council of Governors as a default partner that also provides a catalytic platform for advancing cross-county learning and scaling up sustainable high-impact interventions to accelerate health equity. Now, beside the work that we've implemented in more than 32 counties in the country, we've been deliberate to strengthen and collaborate with the Council of Governors through various introduction and scale-up of revolutionary innovations within the health sector. And some of the areas that we've worked directly with the Council of Governors as well as the counties is the introduction of the malaria vaccine. As you all know, Kenya was one of the pilot countries of the very first malaria vaccine globally. Accountability for financing for maternal child health under the Global Financing Facility that is dubbed in-country as the Transforming Health Systems for UHC. We've also partnered in the nurturing care, which falls under our ECD program, as well as advocacy and public policy. Over the past 15 years, in partnership with the national and county government, we've catalyzed key policies, we've mobilized resources to bring health solutions to scale and ensure sustainability of impact. Now, building on the support of policymakers, of national and county decision makers, of advocates, of influencers and citizens, as Path Kenya, we deploy advocacy to influence planning, prioritization, as well as investments, really undertaking budget analysis and tracking and supporting health advocates to hold government officials accountable for service provision and as well as utilization of resources. Our model to advocacy and public policy is really based on evidence. It's evidence-based policy, as well as skills building, tool development, and catalyzing peer-to-peer learning, as well as establishing and strengthening advocacy coalitions, which underpins our response. Drawing from the experience we've had across the 32 counties, moving on, from this year moving forward, we have adopted a two-pronged approach. One being scaling deep, and here I'm talking about really increasing impact in the counties that we have focused on, as well as scaling out, spreading out to new counties through existing structures of governance, such as the Council of Governors, as well as the regional county economic blocks. A good example is LREB. We have worked very closely with LREB to really scale up the learnings from the counties, and also we are moving to the Southeastern Economic Bloc. With the recent leadership transition at county level, I must say there are more opportunities to build stronger and more resilient health systems that are person-centered. And I want to leave you with 5 approaches that we want to suggest and also define our approach to our work, and we really hope that the counties can partner with us. One is really deploying technical advocacy and strengthening the capacity of county teams and decision makers to prioritize preventive high-impact interventions. The second one is around strengthening the health policy and legislative environment. And as I mentioned, we have worked with key decision makers, including Parliament, to pass suitable policies for our programming. The third area is really using data and evidence, and use that to inform decision making. It's very exciting to see at the national level there is the launch of the digital health platform, which really consolidates, all our digital health work. And for us, we are keen to align with that to ensure that there is interoperability with the systems that we deploy as partners. The fourth approach is really building the capacity and equipping the healthcare workers through adoption of human-centered design to really ideate solutions that are feasible, implementable, and sustainable. And we've done these from Marsabit to Kitui to Homa Bay to every corner of this nation. For us, we say as we innovate, let's not innovate for the users, but we innovate with the users. The last area is really investing in primary healthcare, while working together to reduce inefficiencies that lead to financial wastage and really harness the power of the private sector and development partners to address some of the iniquities that we see within the healthcare space. I think we all agree, the health sector is faced with limited resources, and we really have to get creative and innovative in how we allocate these resources and how we prioritize. To our CECs for health seated here, we may be sitting here today representing our individual counties. But in the words of the Director of Health Sector Coordination, Dr. Lanai, and I like to refer most of the time to his statement, we are 47 counties, sort of representing 47 governments, and then we have the one government at the national level, but we are one nation. I think we all need to remember that. So ultimately, let us have a one health approach to deliver quality care to Kenyans. And I want to urge you and nudge you today that the fire we light here today, that it may be fervent and ferocious until every zero-dose child has been reached with life-saving vaccines, until every adolescent, girl and boy has access to critical information and quality health care, until every young woman and young person reaches their full potential as we reap the demographic dividends, until every citizen is able to access decent and quality health care. As PATH, I want to really thank you all for listening to me, and as I've highlighted, we are ready to serve and partner with you, and once again, congratulations. Thank you very much.
Thank you very much, Caroline. You've had 32 counties, right? So after break, just, go and whisper to her, is my county among the 32s? But for us, we'll always say, kindly reach out to all the 47 county government. Please, if you are working within 21 counties, expand and reach out to all the 47 county government. So I know you are 32, so you are remaining with a few, but the CEC seated here, kindly see how you can be able to reach out to her and ask, among the 32, is my county there? If not, are you also adding me? Please, you have to push, You have to push and show that you have the interest. If you are quiet, then you may find yourself out of the game. So make sure that you are also within the circle. So at this juncture, after 3 ladies, let me invite Mr. Harun Hassan, CEO of National Council with People Living with Disability. We felt that it's very, very important to work with his office, because these are the people who are also representing, we also have these people, we want these people to be represented in any sectors that we feel is very important. And I think it's very, very important for us to always involve them in our meeting, because when we engage them, we'll be able to understand their also needs better. Karibu sana. I've seen Harun when he was on the other side. So he's not a new person to me. Maybe he will be able to tell you, where did we meet? Thank you. So, Mike.
Thank you so much, Akatra. And I will say where I've met you, when I was a boy. Your Excellency Governor Mudomi Njuki, the CECs who are appointed and those who are reappointed, congratulations. The development partners in the House, some of them we have worked together, we have an engagement with. All protocol observed, mabibi na mabana, hamjambo. Tuko pwani, lazima tuongee Kiswahili sio? Your Excellency, yesterday when you said hi to me when we were getting into the plane, and you gave me the hug, the guy who was supporting me, kupanda ndege, was from your constituency. Then he asked me, that's my governor. Then I told him he's my friend also. We have worked together and we have met him twice now. And we are going to the same meeting. Please greet for me. So I want to pass the greeting to him. But that small engagement inspires the young man up, and he changed his perception toward me. You mean anakujua? Because of maybe the tag I have, that I shouldn't know some people up there, right? So I have passed the greeting to him. The best thing that has happened these recent decades is devolution. Because of equity and equality. That's why from the far-flung counties where I come from, like Mandera, you hear of cesarean. Because the service is going closer to people who really matter. But there are people who really are more marginalized, and super marginalized within those marginalization. That's what today I came to demonstrate to you in a few minutes that I was given. I'm currently the Executive Director of National Council for Persons with Disability, the state agency mandated to promote all inclusion right of persons with disability in this country. And my journey to this docket was not very obvious. I was a government officer serving as a district officer. That time, I didn't know anything to do with disability. and I never cared to know much. Just like any young man or young woman in the house, I had a grand plan for my life, and disability was not a part of that plan. And then accident happened, pop, I find myself on this wheelchair. And then the doctors in the house told me, I will never walk again. You can imagine how that could define you. That clearly thrusted me into a whole world of disability, from personal battle to theological perspective. Why me? Why disability? And then to even academic. How do we manage matters disability in the society? You know, disability over many generations has been defined in three main models. One of the most unfortunate model is what's called moral model or religious model. In this model, disability is viewed as a mystical act of God, a punishment for a sin. Persons with disability or those who believe in this kind of a thinking, you know, find themselves usually marginalized in all facets of life. But unfortunately, this is a very wrong interpretation of both Quran, Bible, and many religious, many books. Very most recent World Cup, this young man called, you know, Ghanim Al-Muftah, and that famous actor, Morgan Freeman, were quoted, you know, an ayah from Quran on inclusion, diversity, and inclusivity in the society. And I read, it's from those of us in Muslim in the house, from Surah Al-Hujurat 49:13. It says, "O humanity," I'm sure you have watched the opening remarks of the World Cup. That's a clear testimony. Morgan is also a person with disability. His left hand is paralysis because of road accident. The young man you have seen, he has no lower limb. And they have made him an ambassador of FIFA 2022. A powerful story. And the ayah reads, "O humanity, indeed we created you from a male and a female and made you into peoples and tribes so that you may get to know one another." But the emphasis is here. Surely, the most noble of you in the sight of Allah is the most righteous among you. It never indicated that if you come from community X, you are superior to community Y. The noble among you, those who practice the righteous among you, are the ones. And then my Christian friends also, on the other hand, insist and always reminds me that we are all fearfully and wonderfully made, and that God's works have no fault. So nobody has any fault. The other model, which is quite resonating with the audience in the house, is the medical model. On this model, disability is viewed as sickness, a medical problem, a defect. Emphasis is given on what is wrong with a person, making it viewed as a personal tragedy model. In this model, it is expected that a person with disability ought to play the sick role for them to benefit from any help. This is what we contend with. Even my own family up to now, they believe I'm sick and one day I will wake up and go, even when I've removed that from my mind. You see, the right-based or the right definition of disability is what I came to share with you here, and what our CECs, Waziris, and the governor in the house should be so much interested in. And that is the right-based model, which provides a totally different perspective. In this model, disability is not about the impairment, but about the barriers present in someone's environment. Hence, disability is not a defect, but a social construct due to attitudes and also ignorance. Take, for example, myself. If this vein is not accessible, I wouldn't have been here. If this simple thing like this ramp is not here, I wouldn't have been up here sharing this with you. That was what disability is all about. Simple thing that we do. Kenya, across all its laws, adopts right-based model in its legal and legislative business. Our first disability law was signed on 31st December 2003 by the then President Moi Kibaki. I shared with Governor Mudomi while we were in Naivasha a few weeks ago. Barely months after coming off from a wheelchair following a treble road crash during a campaign. You remember President Kibaki alipata ajali kidogo? That time, that wheelchair the former president, alikuwa anakalia, meant a lot to millions of Kenyans with disabilities. Harun here was not that time someone with disability. I was among the ambitious Kenyans in wakati ya Rainbow Coalition, that the president, we are set on the journey, you know. That is when they petitioned, and the president literally immediately get out of the wheelchair. He signed that act into a law. And the National Council, where now today I'm heading, was born. And then life happened again. I passed through where President Kibaki passed. I've become now the executive director of National Council. That's how faith can also define our path. The statistics, this is very important, show that persons with disability account for about 1 million in Kenya. A data that is conflicted by World Health Organization's 15% estimation, which will raise this number to about 6 million Kenyans with disabilities. And it is on rise. Road accidents. Kenya roads are biggest killer, and a number are becoming disabled. You know, diabetes is chopping many people's lives. Stroke is here. Diseases. We are talking to the right audience actually here. I'm certain every county here today struggles to know the number of persons with disabilities in their county. The council has made efforts in the most recent years, actually last year and this year, that, you know, in December last year, the government launched the new registration system for persons with disabilities, meant to curb fraud and provide accurate socioeconomic data for persons with disability. I'm glad Chai is in the house, Rosemary. She's part of this journey, the Chai, to make the disability assessment exercise more accessible to persons with disabilities. We work with the stakeholders and succeeded in decentralizing the Director of Medical Services signature from Afya House, Nairobi, to all county directors of health. And this is why it is very important to you. To register a person with disability was a cumbersome before. In the most unstandardized, shambolic manner, assessments are done across the country. The forms inakuja Afya House, waiting for the Director of Medical Services to sign. You can imagine then the frustration someone from Turkana, someone from West Pokot, you know, goes through to come to Afya House to look for that. So we managed with the relevant stakeholder to decentralize that signature. In it, the intention is how can we push this signature to be defined within the context of devolution and healthcare. Such a huge milestone now places counties at the center stage of the disability medical assessment process. The success of this development now solely lies with you. On this breath, through the Council of Governors, Ministry of Health, and other stakeholders, we conducted training of county medics on the new disability guidelines in April this year, about 300 of them. Last week, we also conducted a sensitization and capacity building forum for all the county directors of health, where Governor Mudhomi actually closed the forum for that week. I wish to take this opportunity to thank all of you, especially the CSCs, for allowing your officers to participate in that forum. This sends a very strong signal to what is said, which I will address later, that county government have no interest and goodwill to improve the welfare of persons with disabilities. But as we came to appreciate, policies, laws, and any other forms of reforms are mere words and documents if they are not accompanied by the resources. Ladies and gentlemen, as they say, to whom much is given, much is expected. The signature now is with you. The disability assessment process in the county comes with its fair share of responsibilities. I want to enumerate 5 of them. Number 1 is conducting assessment of persons with disability. Now it is with you. Number 2, booking and keeping records of the clients is with you now. Acquiring conducive and accessible assessment premises is with you now. Refer client for appropriate interventions where necessary. That's also with you now. And finally, to submit the duly filled and signed assessment report to relevant authorities. As the CCMs of health, we urge you that you provide the much needed financing to have all these responsibilities actualized. For long, there's been a fallacy that disability is a function of the national government. A very wrong fallacy. And I want to debunk that fallacy. For long there's, well, this could be as fueled by the fact that Persons with Disabilities Act was established way before devolution. However, we take note that persons with disabilities reside in a location, they don't reside in a location called national. They live among us in our villages, in our towns, in our counties. They don't live in a place called, The Constitution, as enshrined in Article 10, binds all those holding offices to exercise principle of governance, which includes inclusiveness, equality, non-discrimination, and protection of the marginalized. Also, the Person with Disabilities Bill 2021, that is currently at the Senate, intend to also introduce a relationship between how the county government and the national government can coordinate on disability issues. Finally, for starters, we urge you to take up as part of your mandate to visit one of the disability assessment exercises and get a feel of the whole process and the areas that need urgent intervention, such as personal challenges. That's the only time you will come to appreciate the challenges communities with disabilities goes through. This will enrich you with much needed insight to shape your policies, plans, and budget in a way that is conscious of the plight of persons with disabilities in your counties. A huge request from all persons with disabilities is that all counties should offer the disability assessment free of charge. There are some counties that charge as high as 1,000. There are some counties that charge 500, and there are about 17 or 18 counties who charge, don't charge at all. And as we sign CIDP, County Integrated Development Plan, that have a sharp focus on the quality of service for delivery for persons with disabilities as they seek to access healthcare services, many times in our disability advocacy effort, we use this testament that disability is a club that anyone can join, and I'm a clear testimony. For some, this could be akin to the preacher who uses hell to threaten the congregation to offer more offering or sadaqah. However, this statement isn't meant to push the stigma around disability. Instead, it's a call to action that we should have a society that accommodates all of us, regardless of our unique differences. Hence, having a plan that is intentional on leveling the field for persons with disabilities as they seek disability assessment and other healthcare services in general is crucial to having a country that, what Mesha here said, leaves no one behind. Thank you so much, and I also want to recognize in the presence of the CSCs my professor, Professor Mwenje. He taught me at Kenyatta University when I was a boy, and then there was a time he told me, wengine kazi yenu ni kuzurura zurura badala ya kusoma isli. Asante sana, Prof. Thank you so much.
Thank you so much, Harun. Thank you so much, Harun. At this juncture, kindly allow me another round of applause first as he's going to his seat. Thank you very much. I would like to invite Mr. Brian Ratman, Country Director of PEPFAR. PEPFAR is also working in so many counties on HIV, TB, and malaria. I know he's also somebody now to link with immediately after this meeting. He has his people here. And we are very glad and happy because you managed to bring for us all the 47 counties here in this forum. Thank you very much, and karibu.
Asante sana. Honorable Governor Njuki, CECs, both new and continuing, hungara sana on your appointments. Representatives from the Council of Governors, fellow speakers from AMREF, CHI, Jacaranda Health, NCPWD, and DPHK. All protocols observed. Let me start really by saying how excited I am to be here today. I'm hoping to build on our progress and really look forward to working with you all to reach and sustain epidemic control, HIV epidemic control, in an open, transparent, and collaborative environment. My name is Brian Rettman. I work, as mentioned, with PEPFAR. For those of you who don't know what PEPFAR is, it's the U.S. President's Emergency Plan for AIDS Relief. We've been working for the last almost 20 years to reach epidemic control for HIV. And the good news is we're close. We're very close. We have about 1.2 million, or I'm sorry, 1.3 million of the 1.4-ish million persons living with HIV on treatment in Kenya. But that means we now need to look at how we're going to continue to evolve that program. And in order to make sure that we sustain those gains moving forward. So first of all, I do want to also mention that we have a new ambassador in Washington, John Kengasong, who is coming from the African CDC, and he's put together a strategy We call it the 5x3 strategy, but the 5 pillars of it really are meant to help understand how to have that long-term sustainable program. The 5 pillars are built on health equity, sustainability, health systems, building new partnerships, and lastly, science. So as you know, or as I hope you know, PEPFAR really is about continuously evolving to improve. And although I've grouped kind of 3 main themes into what I wanted to discuss, and I like the 4 Ps that were presented, I also have 4 S's that I'll come back to as well, so that we can get through a full set of alphabet. But the 3 that I really wanted to focus on of those 4 S's are supply chain or commodity security, data systems or strategic information, sustainability, and then the last S, which kind of ties in with sustainability, is also the service delivery that we work on. So these few critical areas we really need to focus our attention in the coming years as we really continue to progress across HIV prevention, care, and treatment, as well as systems work. When I look at how the world understands PEPFAR's success, people first look at the number of people on treatment. As I mentioned, we've got a lot of people on treatment, about 1.3 million patients. They also look at prevention, and because that's a lot of, it's really kind of fun to be working with adolescents and with the other prevention populations. But what's often overlooked is really the systems work that we do. And so within that systems work, as we're building labs, as we're ensuring that commodities and supply chains are operating, as we look at the data systems, we really have to look at what's in place to ensure that the whole program is functioning. And I think what we've also noticed is that systems work has really helped as other epidemics and pandemics have emerged. And so as COVID came around, really looking at how the lab system that we built up for HIV really helped across the full sector is really helpful to understand where we need to go in terms of building health systems that are interoperable and that are working across the full health sphere. Because what we put in place for HIV actually is helpful to work across. As we look at those health systems that we've developed for the last 20 years, we need to think about how we can continue to integrate them into the overall health system and how those investments can continue to benefit across
to improve access to health services, improve the management of human resources for health, and increase available resources for health at the county and national levels. I would also like to reiterate DPHK's commitment to our partnership with the COG and the county governments. For the past 2 years during DPHK strategic retreats, the DPHK group has identified our partnership with the COG and the counties as the top priority. Development partners' work must always be done in collaboration with national, county, and sub-county officials. And if that's not happening or you feel like the process can be improved, please let DPHK individuals know. And I'd just like to quickly ask Vincent from the DPHK group if he could stand. Hopefully he's still in the room. I know I saw him. Okay, so Vincent is the secretariat of the DPHK Executive Committee. He is our primary point of contact for any engagement. So if you see ways that the development partners are not engaging in your counties, please bring it to Vincent and we'll discuss it at the executive and more broadly. I also know from the Governor's Health Committee meeting 2 weeks ago here in Mombasa, many governors and county level officials are concerned about a perceived lack of transparency and coordination of development partner activities in their counties. So, as I said, the DPHK group is committed to working in the counties, to working with the COG to that effect. And if there is something that you feel is not working well enough, please do bring that to our attention, and we will try to address that. One of the things we've been talking about for quite some time is a mapping tool so that all the counties can see what exactly is being done in your counties, what level of resources, what types of activities. We did meet with the COG last week to discuss how to move this forward. So I'm hoping that it's a question of weeks and not months before we have this information available to you all. I think in the more immediate term, I know that county integrated development plans are in the works across all of the counties. Development partners and our implementing partners are committed to engaging in those plans so that your plans and our work are aligned and our work that development partners are supporting achieves the goals that the county governments have set for yourselves. I must make one quick note so that I don't get all of the other development partners in trouble. There are some limitations to the flexibility of our funds. So if a partner, if an implementing partner or an NGO receives HIV money, it is very hard, if not impossible, for them to use that HIV money to build a maternity wing in a hospital. So we do want to be as flexible and collaborative and coordinate to the greatest degree possible. But there are some times when there are limitations, legal limitations to what that money can be spent on. And so finally, as Kenyan government resources increase with the economic gains that Kenya has enjoyed over the past decade, which is really a success of the Kenyan country, and a testament to the very rapidly growing economy here. As development partners, we hope to leverage county, national, and development partner resources to ensure that the COG and the counties and the national government continue to strengthen capacity to support all of you. So I would like to close by once again congratulating all of the CECs. Your service to your counties and the people of Kenya is inspiring, and the DPHK is here to support you in that mission. Asanteni sana.
Thank you so much, John Kinley, for those good words. So another round of applause as he sits. So kindly allow me now to invite His Excellency Governor Mudhomi, the Chair of Health Committee. Let us all be upstanding as we welcome him. Tumpigie makofi mpaka afike hapa. Karibu sana, Your Excellency.
Thank you very much. Before you sit, just give me this. Thank you very much. Mombasa is an interesting place, but sometimes can be very soothing in terms of the temperatures. We can be seated kindly. The Deputy Governor of Isiolo County, Dr. James Lowassa, who is also the CC for Health, and our distinguished guest for the reason we are here today, the CC members for Health from all the 47 counties, our development partners led by John Kinley, who is the DPHK chair, Brian Redman, the director of PEFA, one of the development partners, our friend Harun Hassan, the CEO of National Council of Persons Living with Disabilities, the county director of PATH, Madam Caroline Juguna, Cynthia Kaumbura, who is the county director of Jacaranda Health, the representative of CHAI, the deputy director Rosemary Kihoto, AMREF CEO Dr. Meshek Dirango, our secretariat that is represented here fully in all numbers, headed by Ketra and representing the CEO in absentia, our friends and partners. Good morning. Good afternoon. No, good morning. Good morning. God is good. And all the time, even today when we are here to deliberate on issues that concern our people, very pertinent to health, because without health we have no wealth, and even all the other depends, we cannot be able to work. I want to first and foremost congratulate all of you for being appointed or making it to the list of the CEC's M for Health for all the 47 counties. I would like to single out those who have been reappointed again for the second time, because that's not a mean feat. I know we are several of them, including those who have moved counties, and I'm very, very sure we are equal to the task. That is why we are given that task, to be able to represent the counties. I stand here today not in my personal capacity, but to represent all the 47 governors of Kenya, and in particular the Health Committee that is made of 15 members, who I will speak their mind, or I will say what we feel about health. And therefore when you see me here, you see your governor, because we represent them and represent their views. And I know all of them by name, from Lamu, Kwaisa Timami, to Turukana, my friend Jeremiah, to here Kwale for Achani, Kisumu, Kwanyongo, and every other part of this county. We all speak the same language, irrespective of our political backgrounds. And that tells you that when it comes to the matters of COG, we put all the affiliations aside and focus on one agenda, that of building the 47 counties of Kenya, and by extension, the nation of Kenya. I am honored to join you today. First, I would like to say that I'm very delighted to be here to join you in this particular induction. It is a very important induction, because this is going to help you as a member of the DeVoe family to be able to advance the agenda for health in this country. We have convened here today jointly to discuss, share, learn and evaluate the status of health services within our counties, and ensure that all of us become better health leaders by the time we go back home after 3 or 4 days. And to make this possible, we have invited various speakers and facilitators who have vast experience in this area. And let me also take this opportunity to thank these resource persons for accepting our invitation to participate in this very important forum. Allow me also to thank members of the COG Health Directorate who are here today, headed by Katra, under delegation by the CEO of the Council of Governors, as well as thank our partners who have invested various resources to ensure that the Induction Forum is successfully held, which I do not wish to mention them by name, but I'm sure you've been seeing them on the screen as we continue with this program. Over the past decade, the governments have played a major role in guaranteeing all citizens their right to affordable and accessible high-quality health services. This has been provided at all levels of the health system, from the community to the high-level hospitals of level 6. We have done this through building health infrastructure, investing in our human resource for health, strengthening our health information systems, and strengthening the supply of medicines and medical technologies. In addition to these county governments, with the support of the Council of Governors, have paid critical focus on adapting learning by nurturing learning both within and between the counties that are represented in the 47 counties. We acknowledge that all of you come into this space with rich experience from various sectors, as we have heard during your introductions. As such, the COG Health Committee proposed this induction meeting as a platform for us to collectively learn from each other. We were here about 2 weeks ago, and that is when we insisted that we must have your induction early before December, when you're still fresh and we have energy because we've just been appointed. We are hoping that you'll share knowledge, ideas, innovations, practical strategies, and candidly discuss issues of common interest in health to accelerate the achievement of universal health coverage. Let me now highlight a few critical areas that I hope will be well debated in this very important forum. Firstly, ensuring sustainable health financing. As we all know, the health financing is a critical pillar of any health system. We need to critically and continually ask ourselves how best we can ensure that the Kenyans have access to health services when they need them and at a cost that they can be able to afford. The Council of Governors has been at the forefront of this discussion, and as CCM Health, this is definitely your priority. We have invited here the leadership of NHIF to this forum, who I saw they are well represented, so that we foster these discussions, but also allow you to have first-hand discussion with NHIF, even on the sidelines. Secondly, strengthening health services. About a year ago, the Council of Governors critically reviewed Kenya's health and demographic profile, as well as other important factors, and concluded that there is need to step up preventive health across all the health program areas. We noted that in contexts like ours, failure to invest adequately in primary health care is likely to cause unsustainable increase in health costs. We are operating in a context where most counties have limited fiscal space, investing over 30% of their budget in health despite having 14 devolved functions. Donor funding to health is also reducing, yet there are continuous emerging needs for further investment in healthcare. And as we continue to advocate for better funding of county governments, we need to optimize all our resources to get the most out of each shilling spent. We know that early investment in effective prevention would enhance good population health, reduce morbidity and mortality, including from lifelong chronic illness, and save resources in both healthcare and social services. A shilling invested in primary healthcare has been found to save 5 shillings in direct medical costs and up to 11 shillings on the overall cost of Medicare. As such, this is where we need to start. It is my hope that this induction forum will enable us to critically discuss how to increase investment to preventive health, including for non-communicable diseases. We also need to discuss how to foster community health services. Secondly, we need to look at how to best optimize health facility services, right from the dispensary to the county referral hospitals. As you know, human resources are extremely critical in the delivery of health services. We continue to seek county governments to prioritize human resource for health capacity, including ensuring that we have the right skills for the job. We also need to ask ourselves if there are health services the countries can share through our platforms, like the regional economic blocks, and especially if you are looking at specialized services that need optimal numbers to be cost effective. This sharing across the counties would definitely boost the numbers. Thirdly, the supply of medicine, technologies, and commodities. We all know that the availability of health products and technologies to the last mile remains a critical pillar to any good health system. As such, this is an area of cross-sharing between the counties. We need to look back and ask any improvement necessary to improve effectiveness. But also, we need to discuss how best to link the HPT budget to quantify needs for medicine, as well as other medical products and devices. County government need to be innovative and use preferential procurement regulations to obtain better costs for health products and technologies. We have invited the KEMSA leadership to this meeting so as to further have the discussions around this area. Finally, ladies and gentlemen, delivering the promise of responsive health system requires our strong leadership. Not only leadership, but also innovation and getting value for every shilling invested across all the building pillars that builds the health sector. The COG Health Committee will work closely with the national government and other stakeholders to address critical issues that derail service delivery, continuously advocate for sustainable and innovative healthcare financing, and provide platform for continuous sharing of information and knowledge amongst counties in favor of devolution. I wish you all a very fruitful engagement. And before I finish, having spoken the minds of the Council of Governors on the issue of health, as the chair of Council of Governors Health Committee, I also want to put my personal notes on this as the chair. In the year 1988, or between 1988 and the year 1989, the health funds or monies that collected in health facilities, all of it used to be swept to the treasury and used collectively as one kitty. Under the president, the late President Emilio Moi Kibaki, the Health Reform Secretariat was formed at the headquarters. It is during this time, through this leadership, that he advocated that 50% of all the revenue collected from the facilities should be remain at the facilities, and 50% is taken to the treasury. It is during that time that we started seeing changes across the counties, even without devolution. That is the first time we saw the establishment of ICU unit in Mombasa Coast Referral Hospital, and is extended to all the other hospitals in Kenya. And many other reforms, including giving autonomy to Kenyatta National Hospital, that used to be part and parcel of just the ministry. It is for the first time the Kenyatta National Hospital was able to pay their medical personnel directly without having to consult the ministry, and also be able to put them in a scheme of service that it could be able to promote them. When it came to devolution in 2013, all those gains were swept away, because today the PMF Act is very clear that all the funds that are collected in the county must first of all find their way to the consolidated account, which all of us put our resources there, and we are aware what normally happens when your funds go to CRF account. What has happened is that we've continuously, as facilities in our counties, collected money from patients. We have swept them to CRF, and when that money comes back, it ends up going to collect garbage, it goes to pay rat catchers, it goes to do roads, it goes to do many other things that were not intended to be able to improve the health sector. And it's for that reason various speakers today, and I remember in particular Katra talked about it, Kaumbura talked about it, and even I think one or two other persons, that the way for the future of our health sector, putting in consideration the rate at which we are falling back on disbursement of our resources from the national government, the only way is to ring-fence these resources by establishing or passing legislation around facility improvement fund. That is our position, and I want to note with a lot of appreciation and also a little concern that facility improvement fund legislation has been passed and successfully implemented in 7 counties, which include Nakuru, Bungoma, Marsabit, Makueni, Taita Taveta, Narok, and Nyeri. That these counties are able to collect their funds from the health sector paid by the patient, but it finds its way back into this health sector, these health facilities again, without having to go to the CRF account. We also have 17 counties which have FIF registration, but are not implementing it appropriately. That they have it, but they still take their money to the CRF, and we would like to urge those 17 counties to implement it fully, because our resolution as Council of Governors is that by the end of this year, which is the next year, 2023, that all the 47 counties should have FIF account so that they can be able to ring-fence the resources that come from facilities. Otherwise, you will find yourself in a very awkward situation where you will be funding the gap that is existing between the disbursement of revenue by the national government. Like now we are 3 months in arrears. We know counties are not being given money for October, November, and now December. So if you're waiting for that money to buy drugs, then you know what is going to happen to the effort that you made in primary health care. Secondly, I am not a debt collector for KEMSA, but those CECs who are here for the second time know that the most affordable quality drugs come from KEMSA. If you have tried other markets, you know that the cost of drugs outside KEMSA is about 3 times. We may be hiding behind what was alluded to be the KEMSA of that time of COVID, but this is our institution. With the sector reforms that we have participated in as COG, and I want to confirm last week, we were able to get a representation on the board of management of KEMSA, and therefore we have no reason to say we are not part of it. We would urge the counties to pay debts that they owe to KEMSA. At the moment we stand, we are at 3 billion debts owed by counties only, leave alone the other organization, because Kenyatta Hospital and KU referral are not part of the counties. But counties alone all KEMSA 3 billion Kenya shillings. And therefore, we urge you to prioritize on payment. And KEMSA is here. It is not possible for us to pay your debt when we are not buying drugs. When we start paying your debts, then give us more debts. It is a question of get supply as you pay, so that you keep on reducing your debt and also getting the supplies. That way, we'll be able to ensure that our people get quality drugs and also cost effective. The issue of NHIF has been raised here. We will not be able to achieve universal health care without ensuring that counties take active role in enrolling our people in NHIF. The total money is required for NHIF per person or per family is only 6,000 per year, 500 shillings per month. Look at the expenditure for your people. How much do they spend in luxuries and other things that don't concern their health? But they are not aware. Unless you tell them, unless you lead them, it will not be possible. And we know our people are driven to poverty nowadays because of just having one disease ravaging their family, and they sell everything while trying to deal with a disease that would have been prevented early enough if they had NHIF. So again, I am not, I don't work for NHIF, but as a Council of Governors and the Chair, I know it's profitable for us to be able to invest in NHIF. Lastly, the CEC. And this one I will speak candidly without, I will give regard to the ministry, but allow us to speak our language. For the last 5 years, I have seen things happen in Council of Governors that has found ourselves in a very awkward situation that would not have been there if we acted as a Council of Governors. The Council of Governors is a coordinating agent for all the 47 counties. When as a county you decide to deal directly on matters that involves policies with the ministry, then you are becoming the stray goat. The Council of Governors Health Committee is the one that coordinates all the activities of the counties with the Minister of Health. We are saying that because we have had situations where we find issues that have been agreed upon, agreed in quotes by the ministry. They say we had public participation because councils were involved. And then when you go in deeper, they tell you that we engage CECs. And what they normally do is usually call a few friends. If I'm a CEC, if the CEC of Nakuru is my friend, and I'm a director, and I'm not saying anyone in particular in the ministry, I call them, we have a discussion, find me other 5 friends, and we agree on an issue, which does not have any legal advice, or does not have any negotiation and agreed position by the Council of Governors. And then you put us in a very compromising position. We have, as a county, or as a Council of Governors Health Committee, we have agreed that this time round, and we urge you CECs, let us engage through our caucus. I am aware that today, after the deliberations that we'll have here, you will be going home having appointed or chosen or elected your caucus leadership for the Council of the CEC caucus. I want to give my personal commitment that we will engage the caucus directly. We will not be just engaging the ministry, engage the governors. We will engage the caucus directly. I'm saying that because all the 47 governors are not in the health committee, but they have trusted the 15 of us to be able to negotiate, to be able to make decisions on their behalf, which of course we always report to the full Council of Governors. So for us, we will engage the caucus. So when you're doing the leadership today, you're not just doing a leadership, you are doing your bridge to the negotiations with the Council of Governors with the ministry. And I would not wish to put in another language, because we have had efforts to claw back on devolution using shortcuts, loopholes. That is an excuse that we engage the CEC members. Of course, when you call for a seminar, it's very enticing, isn't it? They will call you for seminars directly. We have said, don't be called for seminars again directly by the ministry. When they want to call you for a seminar, they will call you directly. We have said, don't be called for seminars directly. We have said, don't be called for seminars again directly by the ministry. We have said, don't be called for seminars again directly by the ministry. When they want to call you for seminars again directly by the ministry. We have said, don't be called for seminars again directly by the ministry. When they want to call you for a seminar, When they want to call you for a caucus, when they want to call you for an engagement workshop, let them do it through the Secretariat, the Council of Governors. Your governor will not even ask where you are, because we shall have reported where you are through the council. Lastly, my good friends of CECs, you are the technical advisors to the governors. You know, governors are busy people. There are very many other ministries to take care of. I am sure your county has more than about 10 departments that are represented by CECs. So the governor is taking care of all of them. On the matters of health, you are the principal technical advisor to the governor. Do not wait for the governor to learn from the Council of Governors what is happening in health. You are the person who knows. Aaron has given us an insight of what is happening in the council, PWD. I mean, that's an expert. We may not have an opportunity, all of us, to engage Aaron, but you do. And I'll tell you how. You also are a busy person. But you also have a technical advisor that has been put in place by the law for you. Many of the CECs have no regard. Not many, but a few of you. And I'm talking about the ones who have been there before. And we are speaking from knowledge or informed point, because we discussed with these governors. You have a person called the County Director of Health. How many of you engage them? Why do you always try to do, I don't want to call it donkey work, but work that you would have been doing something else? If you allowed your technical person, who is the Director of Health, to do it for you, put them to task. As much as you are the technical advisor of the governor, also allow technical advice from your technical person, because most of you are not medics. I know a few of you are, but I don't think there's any county director of health who is not a medic, because that would be against the law. And that is a person who knows that technical language that is being spoken here by Brian and John Kinley. So let us use them without reservations or feeling as if they are taking over our work. It is also prudent that you don't allow your county directors of health to be what we normally call workshop hopping. That in a whole year, your director of health will start from Mombasa. He'll change planes at Jomo Kenyatta National Airport, land in Kisumu. When he comes from Kisumu, he lands in Jomo Kenyatta International Airport. He'll be in another workshop in Kwale. And in all, maybe 1 year, 12 months, you can be able to count how many times he has been to your county referral hospital. Don't allow it. Because again, it is very enticing. And how does it happen? They are again called directly by the ministry. I don't want to touch our donor partners, because if I touch, our money will go. But it is important. I'm just saying, let us have a system that communicates, and let's have order. Don't allow them to just be hoping. And I'm sure I am speaking to the hearts of some of you who have experienced that you're in the hospital, you have a donor who has come, and you cannot find your director of health because you was called by the minister or the PS, or you was called by, directly. Just they have a letter, and when you're called by a minister, that's a very superior person. Who are you? You're just a CEC. They will go. So let us put systems in place so that at least we can have a working nation. With those very, very many remarks, I know I've given very many of them. I want to wish you a very productive workshop, and look forward to working with you in these 5 years, and looking forward to working with a caucus. When we can't be able to find you, we'll be able to find your caucus and work with them. Aaron, I am inviting you to my county. We will work out on the details, because I have seen light that I had not seen before. There's a lot of potential in ensuring that PWDs in this country enjoy even better rights than we do, because the people who don't have PWD are privileged to be where they are today. Thank you very much, and may God bless you. Enjoy your workshop.
Thank you very much, Chair, for those very, very many good remarks. At this juncture, when you look at your program, but first of all, let us give him a very nice applause. Yeye ni mtu ya Nyayo, so tunampatia ile ya Nyayo. Ama Your Excellency ulikuwa ni digital. Amesema ni sawa, so tumpatie ile ya kilo, ile ya kufunga na kufungua. Tusimame, kwa sababu tukisimama program itachange kidogo, alafu tuende chai. So tumpatie 1, 2, 3, funga, fungua. Asanteni sana. So as per the program, now we are supposed to have a presentation. We are very behind, but because we need to just come back after tea, but before we go for tea, I'll ask all the CCs, newly appointed CCs, to be up here. We are going to have a photo session with our chair, and then after that, the other partners and the rest who are in the room will also join us. So our communication, Muka, Mebo Muka, our photographer. So all the CCs kindly come here. The secretariats come in front kindly, we just adjust here. So CCs, Hello? Tea is served on this side, just within the conference room. Kindly check. Just take 15 minutes because we have not yet started the program.